All right, I think we're gonna go ahead and get started. Thank you guys very much for coming. I really appreciate on a Saturday morning at 7 a.m. To come. That is very gracious of everyone. So just a little bit about me. I am what I would say, Dr. Serena would say, I am a woundologist. So I deal with chronic wounds all day, every day. For the past approximately 20 years, I'm in the Las Vegas area. We have our own practice of about approximately 15 different clinicians, and we see patients across the entire gamut of the spectrum of wound healing. So we see patients in the acute care, LTACs, all the post-acutes, outpatient wound centers. We have our own offices, 3 of our own offices as well. And we have a multi-specialty group as well. So full disclosure, I opportunity to go and actually see the machine out on the floor there, and we do have one here that we can do a demonstration at the end. But this is really the newest and greatest technology for tissue oxygenation. So what exactly is near infrared spectroscopy? What are we doing? Why do we have it? What are we thinking about? And those of us who've been practicing for a number of years have seen the evolution of oxygenation and how we are evaluating that, right? In our own office, and I think going through the basic sciences of this is sometimes a little bit belaboring, and we'll go a little bit more into the case series on how to utilize it, because I do think that there's a learning curve for those of us who are clinicians on how to use it. But this is very important for you to understand that we're not only just looking at macrovascular flow, we're looking at the microvascular flow. And I think we spend an exorbitant amount of time talking about how we can reinstitute blood flow to the area, where interventions, what kinds of interventions. But I think we also need to start thinking about our end organ tissue perfusion. Are we really getting the end organ value? And I don't think we think of skin as an organ and what we need to be doing for that. So just to give you a little bit of background on the colors that you're going to see. So low oxygenation, saturation will fluoresce blue. What does that mean? That means that there's decreased oxygen supply, so decreased local perfusion. That does not always necessarily mean that there is some sort of massive blockage in a macrovascular artery, but it could mean that you have decreased cardiac output. It could be anemia. It could be a variety of tissue, skin dermatological disorders. So you do need to think very critically as to what your differential diagnosis is when you're looking and evaluating these pictures. High oxygenation, it will fluoresce red. And so what does that mean? Increased oxygen delivery. So we utilize this in many different ways. And obviously one would be revascularization, pre and post intervention. Could we see an immediate improvement in that tissue oxygenation there? Yes, we can. Any kind of therapeutic tissue intervention. So we use a plethora now of very, very expensive high-end advanced products, right? And I have utilized now the machine. We use it in our practice on an everyday basis, and I use it also to justify to those insurance companies, to justify my clinical outcomes on why I am using those products and when I'm using them. And I think that that's very important in our decision-making algorithm. Those of you who still practice hyperbarics, I do. We use it pre and post hyperbarics as well. It really does give you an evaluation very quickly on if you are getting the result you're looking for, and if you are not, along with your clinical acumen. Please stop and reevaluate and change your medical decision-making algorithm. Decreasing oxygenation utilization also. So if there's any mismatch perfusion, we should be astute to that. Any kind of mitochondrial dysfunction, which is really sometimes in a chronic inflammatory state, you're going to see this mitochondrial dysfunction and an inability to use the oxygen. So you may see a hyperoxygenated area. Again, the really basics of it all is that, we're able to distinguish between the oxygenated and deoxygenated blood. We do fluoresce down to a penetration of about 3 millimeters down underneath the skin dermis. We also see these are the light wavelengths that are being fluoresced. And finally, we are able to use their algorithms and in their imaging, be able to get an image that we can see. I put this up for two reasons. One is that this is something immediate that you can see. We'll actually do a demonstration today for you guys to evaluate that. If you put a tourniquet on the finger, you can actually, you will see 4 different images, up to 4 different images, depending on how you look at the interface. But here you have the oxygenated blood, you have the oxygenation percentage, you have the total hemoglobin, you have the oxygenated hemoglobin, and then you can break that down even further to the deoxygenated hemoglobin. So when you see the actual interface, it's quite robust. You have a lot of features on the interface itself. It is a touch screen, so you can touch the areas that you would like to fluoresce to see what the oxygenation is. It has a measurement that you can do, and those are fairly accurate. We've gone through this quite meticulously to ensure accuracy of those measurements, and they've been actually very, very, very accurate. Those of you that are doing reconstruction or pre-intervention, I think it's very important that you can also freehand measure certain areas. So for example, if you're doing surgical management, you do need to do some mapping. You need to understand my flap. Does my flap even have where I'm potentially going? Does it have enough oxygenation for that to survive? And I think that these images are very important once you start utilizing them into your practice, that not only can you use it preoperatively for planning, but postoperatively to ensure that your surgical outcome is really, truly what you're looking for. In this day and age, I know we're an international crowd, but more times than not right now here, they're judging us for our outcomes, and particularly any type of surgical outcomes, because it's costing money. I think we had a large discussion over that yesterday. And so everybody is getting a grade in some way, somehow. And so if we're utilizing certain technologies to improve our own medical decision-making algorithm, I think it's the wave of the future. And to be able to adopt that into our practice now is really the way that we're going to have to start thinking about this for the future. Here you can also click on these and you can see side-by-side comparison. You can see the image that I showed you before that has the oxygenated blood, the deoxygenated blood. You can also toggle between those, and we can show you the demonstration a little bit later. So I think the more important aspect is, how do you use this in real life? How do you use this on an everyday basis? And I really and very strongly implore you to try to implement some of these even in one half day of your clinic, or in your 1/2 day of an OR, because I think it really gives some great information. So you can see here, we had a patient prior to amputation imaging. And you can see that it's a little bit difficult, but there it shows about 40% oxygenation there and about 64 here. So nonetheless, the amputation was performed. To the naked eye, those of us, we've been practicing a long time. I think we take for granted that we have a certain clinical acumen that we know and we can predict. But I think most of us could probably agree that this didn't look terrible, and you probably couldn't demarcate exactly where the issue is really happening. And lo and behold, there really is a significant amount of decreased oxygenation there, and likely this is going to dehisce. And so could we, prior to getting out of the OR, could we release that surgical line? Do we need to put a graft? Do we need to use different surgical technique, et cetera, to avoid a postoperative complication? That's really what we're looking at. I so apologize for this picture. It's so dark. I wish I could have lightened it, but I hope that you guys can kind of look a little bit closer, but there is a large black eschar here. And obviously this is a TMA. The surgeon had probably knew that she needed to have a BKA, but it is what it is. We do this all the time, right? And we're trying to salvage. And because this is such a large black eschar, none of us know if that's going to survive or not. So we did an image, and lo and behold, majority of that surgical line actually had some tissue perfusion, but there was an area here that was in question. And sure enough, and this one was taken on August 9th, 2021, and this one is August 19th, which was just a few days ago. We saw the patient, and again, lo and behold, majority of this surgical line is healing, but the one area that was in question is still in question. But again, we've had variety of different interventions that we've done with the patient to ensure and instill greater oxygenation to the area. So I do anticipate that the one area will heal eventually, but it may take us a little bit more time and effort into instituting more blood flow. Vascular intervention, once again, you know, the skin is an organ. And so are we getting end organ perfusion is really what's interesting. And I think it should be utilized in addition to post-intervention imaging. So, oh, excuse me. So here we can see there are no wounds here. This is a clinical claudication that the patient was coming in with. Pre-intervention, we can see that there is a significant decrease in oxygenation here. I caution those of you who are using the technology for the first time and only looking at colors. I do think that the colors can be somewhat deceiving. And so actually putting, it's a touch screen, so putting your fingers or a stylus to actually check the areas of oxygenation is very, very important. It's important to also check the surrounding tissues as well, and to really get an average of the entire area. But you can clearly see with the colors alone that post-intervention, we were able to get a significant more oxygenation to the limb. Guiding and debridement in your office. You know, unfortunately, many of us cannot go to the OR, or a lot of my patients are unfortunately non-operable, you know, when they've had multiple procedures and they come and they're say, you know what, go to Dr. Wahab, she'll fix it. You know, we just can't take you continually back to the OR. So here we have an Achilles area. You can see here by naked eye, it's very difficult to see what is that, what's going on. Is this area going to heal? Imaging, majority of this area is blue and somewhat pale. We're not getting as much oxygenation there. Post-debridement, so it can really guide you to continue to debride. How much do you need to debride? And where do you need to debride? That could really institute greater blood flow. It's very, very important. And you can kind of just as a very obvious pictorial. This is another one you can see, and what I want to show you is that the numbers are very important as well. And sometimes you may not realize that the numbers don't need to be a significant improvement, but an improvement. So with this technology, it's very important that you start, and it's a comparison over time. Okay. Yes, you can get a snapshot. Yes, you can get an idea and an average on the one time, but really where the magic happens is when you're taking serial images over time. Serial images from your interventions, whether they be topical, whether they be surgical, it doesn't matter, but that over time. And you can see here, just with debridement alone, you can see right here in the middle, it was 67% pre-debridement and post-debridement 76%. Yeah, it looks a little bit more clean, but it doesn't look significant by the you know, naked eye on what was actually done. But we can see that also that the peri-wound is also improving as well. Also, to understand your healing trajectory. I think that's important as well. I utilize this. We have insurance contracts, right? And they want to talk to me every month about their patients and why their patients are not getting better or that they're getting better. And so I pull up a lot of these images to actually give them hard data, not just a pretty picture, because a pretty picture can be given by anybody, but really to give them hard data that no, this is a very tough case. These are probably non-healers in our trajectory of patients. And how are they healing it with our interventions? And so you can see just from March 5th to March 24th, we had an improvement over, again, I can't see by visualization. It doesn't look much different to me, but really there is an improvement over time, and it might be that slow, steady improvement, but there is something occurring. Another patient, 72-year-old male with history of diabetes, peripheral vascular disease, and he had a number of interventions, and pretty much, again, was non-operable at this point. We had healed him significantly, saved his feet. He had multiple wounds on both feet, and this was the last one left, and we are struggling. So we took an image to see what was really going on, and my concern was that his intervention had failed once again, and it does kind of look like that. But nonetheless, we went forward because again he was non-operable at this point. So what was going on in our minds was what could we put on the wound that could increase oxygenation for tissue perfusion. So you can see here that we started looking at, and I put this view here for you to understand that you don't only need to be looking at the oxygenation view, you can be looking at the total hemoglobin, the deoxygenating hemoglobin, and the oxyhemoglobin. The reason I was looking at this particularly is because, as you can see here, this image, the patient has a lot of fibrotic skin here. I didn't know if that was just some sort of glare off of the camera, what was happening. And so I wanted to really be sure that there was something a little bit more that was happening, and that we were really getting the depth of penetration that the machine really is supposed to be giving us. And so the oxygenation was obviously not so good. But we could see the total hemoglobin was there. So I could see that I don't think that this was just the error of the machine itself off of a glare, but that there was some imaging happening underneath that skin. And so what did that mean to me? So nonetheless, we started applying advanced products and hope for some recruitment of angiogenesis and recruitment of stem cells and whatnot, all of the great things that we think about when we're trying to do these interventions. And you can see here that post 7 days of an application of a product, and I'm not promoting any one product, you can see this with a variety of interventions, is that you went from this to this. And so there is movement that's occurring. And once again, justification of you using those very expensive products. And what does that mean? So on an everyday basis, it doesn't necessarily have to be for all of these clinical trials and clinical studies that we're seeing, but on an everyday basis. Now, also, when I started to tell you that my practice, we have about 15 different clinicians, doctors, surgeons, nurse practitioners, PAs, and to scale their knowledge and bring them up to par and teach is very difficult, right? I think we can all probably attest to that. So utilizing some of these also to be able for them to see their immediate response to an intervention is very important. And also for us to go back and evaluate to see if their treatment algorithms are matching everybody else's treatment algorithms is important. And it doesn't always have to be with healing outcomes. We would love to all have healing outcomes, but unfortunately, sometimes healing outcomes are not the only thing that we're looking at. Here's another one here that you can see. You can track the progression. So again, there's a skin substitute here in place that's been sutured after a debridement. And this is what we're hopeful for. We're hopeful that it goes from an area of poor perfusion to an area of greater perfusion. And obviously, hopefully in a proliferative stage and onto the remodeling stage. So you can actually visually see the stages of wound healing with our interventions. Here too, you can really pinpoint, and again, we didn't have a lot of the percentages of oxygenation on here because it kind of clouds the picture and it's very difficult to evaluate. But if you can just look at the colors alone, you can kind of see here that there's better oxygenation than in these areas. And then once the graft was more incorporated, we really got a much better outcome. Pre and post hyperbarics. We obviously have hyperbarics, topical oxygen, all of these things we talked about. Those of you that have been participant in many of the lectures, we're constantly talking about oxygen and all of the greatest and reasons why we look at oxygen. But it's very important in the premise of obviously our technology here. So there are a plethora of evidence-based studies out there talking about the technology and really utilizing it. And I think now with a lot of artificial intelligence, these are now going to be the algorithms that we need to incorporate in our own practice in order to really translate that into good outcomes. So we do have codes. They are reimbursable codes on here, but as a clinician, and not speaking only, for the company, but as a clinician, I think we really need to look at how this is going to help longer term besides just a code that reimburses, right? The codes will come and go, you'll get higher and lower reimbursement, but I do think that looking at this and extrapolating this to saying that your postoperative dehiscence rates have gone down, your complication rate has gone down. Insurance companies are absolutely looking at this and grading us. And so I think we should be on the forefront of that versus on the back end of that. So, but yes, there are absolutely codes that reimburse. So this is really just the tip of the iceberg, and we really need to evaluate what's further inside. And that what may be really lurking underneath our skin is more important. So any questions? Yes, absolutely. And you can absolutely put that. You don't really need it. We should actually show you because there are laser beams that actually give you an even depth. So we'll show you that, but they also are getting the newer versions of the technology, which is great because it's just a computer upgrade that you can also put markers on there and really be able to measure from those markers as well. Yes. Yeah. Yeah. Yep. Yeah, that you're absolutely correct. It was when you first adopt the technology, that's the learning curve that I think we all need to have. One is that, is it a relative number? We don't have that relative number, but those of us who've used it for a long enough time, I can probably safely say that just with no data alone, just my own clinical acumen, that are roughly around 50s and, you know, going into the higher 50s, I feel that I have a chance to implement greater oxygenation. But the beauty is really is the change and really seeing the progression of, and then also seeing where it halts. Okay. And if it does halt, and then the other thing is that when we're talking about the chronicity of some of these wounds, we have that hyper response, right? So we have this really bright red fluorescing. And then also when we're in that remodeling phase, we still have a little bit of a greater red response. Now, what does that response look like 1 year from now after the remodeling phase has been completed? And does that now come back down to a 70%, you know? And we went from 50 to 90 to 70 back to normal. So what is that? So I think we have to, again, do that over time. But yes, I was just talking to the company as well, utilizing that with all of the data that you guys have and integrating that. Does that come out with greater outcomes, and how can we do that with predictive values? And that will be, you know, artificial intelligence. And I think they're already starting, but I don't think I'm privy for that information quite yet. Yes. Right. And I really do think that it takes just repeated clinical acumen in order to really get that number. Right. So as a member of the advisory board, we're actually doing our studies right now to actually give you a quantification of these numbers. So do we have that quite yet? No, we're collecting that data now. But again, just like we did with TCOM or SPP, right? We had a relative value that we were using. And to be honest, they're relatively similar. Just again, from my own clinical knowledge and utilizing this, it's very similar to that. But could I tell you that we actually have those numbers quite yet? No, we're working on that. So, but yeah, right now we're starting to adopt this into evaluating to see how to do the surgical approach. Now, does that mean that it's mapping to really get an idea of whether this needs to be a TMA versus a BKA versus an AKA? I have not done that as of yet, because again, this does have a depth of penetration of about 3 millimeters. So do we really need more than that, you know, for true mapping? Probably, when you're looking up into the AKA. We do about 300 TMAs and BKAs a year. Yeah. Absolutely. Yes. Oh, sorry.
So actually, you start using cats for research. It's really life-changing for us. But what I learned doing research is that it's really it depends on type of application that you're using. Using something, for instance, when we start using these for skin substitute, when you're using integral dermosol, find out that if your value is greater than 70%, doesn't tell us much. That if there is, for example, less than 70%, then the likelihood that study matters for the predictor in that level. Yes. But I have it. Yes, exactly. And this is what we find. We use also for breast reconstruction. This is another
Yes.
different meaning for thyroid surgery to find out that they have a scar. Again, it's completely different meaning. So that's why I'm saying that it's really seems that depends on type of rapid. Trying to figure it out.
Yeah.
I'd be curious to see how it applies to that kind of.
Yeah.
And I think that after, as you also elaborate on that one, is the change. Sometimes when you're saying that, what's the percentage change from the baseline to week one, that you should give also information for the percent of trajectory. Again, the value when it's very high is very hard to sell. Some that you say something like the value is low, in that case, it's going to be
Very interesting to see in these patients. It's too small, that's the disease. Take a picture of this, prior to the revascularization procedure. And shoot it again after the revascularization. Those are PDRs and everything. Couldn't tell those. We're building on 25 years of experience with our surgeons. We look at it and say, yeah, well, I see a lot of change, but, and then it's an educated medical.
But I think the greater question also is where do you, again, what is the normal of just without having a wound? And after that remodeling stage, that number is going to come down, right? So in that chronic inflammatory stage, we really have that hyper fluorescence that we see. And then it kind of comes down. And then you're going to kind of see it come back up when we start to see the remodeling. And then afterwards, what number is normal?
That's true. Of course, that's a comment that the outcome is not linear.
Yes, that's absolutely.
We saw that, yes, if there are less than 60%, seems to become linear correlation with SPP, as soon as they go greater than 60, is confident.
That's, yeah.
But I have a question for you, and this is the struggle that we have with research. I prevent people like to track patient. We know that the value that's reported is related to area that you're selecting. The new software is elegant because it makes it much easier to select.
Yes.
But the problem that we have, and I'm asking for some of my research assistant to track them, ensuring to have the same identical area that we have previously selected and follow them from week by week. And since these should be selected by us, it becomes some subjective and making it a little hard to track and having a fair value report from week to week. You have a plan to fix this problem, something like AI to have matching of two big pictures and then make it identical area, same spot, and see that how that area is starting to be changed.
I think we were just having this conversation yesterday that they are working on that. They are very aware of what we're looking for, and definitely, but just in a busy clinic as well, we have certain protocols. And so we try to put the superior end of the machine always medial to the patient. And so there's orientations that we need to ensure just by the technician taking the image. And obviously there are there's lasers that you can see to make sure that the depth is correct, but also just having, again, those markers so that you can have the markers always there and then translating that. So they are working on that technology and they're rolling out some new things now. Do you want to show that as well, Kevin, while we're answering these questions? Yeah. Yes. Yes. So I don't know if they've already calibrated, but there's a white, no, it's just a white surface. they calibrate off of that and then,
Color scale.
yes.
So that standardization, pre-photo calibration, various standards that we use.
Yes. Same thing. Yes. Yeah. If you're noticing that it's very cold or the patient is very cold, it is going to make a difference. So we do warm the patient a little bit to at least room temperature.
Yeah, when we first got the spine, I know that we have permission as well.
Yeah.
I envision sending my residents all around, and doing these things, it's gonna be great, all these places, right? And then I found out it's like a Xerox machine, right? They gave you the machine for a pretty good price, just so that you can buy the ink.
Yep.
Right? So the spine, it's about $500 a pop every time you decide to use their fluorescent dye. With this, is there an ongoing cost of every time you use the
No.
machine, or how does that work?
No, you can use it and keep getting software updates. Sorry. Right.
Very complicated. Like Joe Bill says, they're different. And you don't look at the exact number that works for each person. That's John's saying. There's a lot of
Yes.
variations. It's hard to be able to look at the pre-intervention, post-intervention. This looks good in this person.
No, I think it's actually, we're here because we're utilizing it ourselves with our interventionalists. And but for the most part, unfortunately, not every interventionalist, especially in our Las Vegas area, is really looking at angiosomes or where the wound is. They may not be able to solve the problem from head to toe, but at least get me something to heal my wound. And so we are absolutely using it. And I think there is the great thing about the technology too, is there's a reporting on it. So a lot of times I will send the report back to the surgeon or the interventionalist and say, this is what happened 1 week post, and they can use it right there, right after the intervention itself. But, we're really probably more concerned about what happens a few days or 24 hours afterwards. And we can actually just send the report right away.
Technology's probably there, but randomized controlled trials there to show this person got this person got that. I think that's really the question that I have.
Yeah, they are currently in the process of completing their randomized control studies. Yes.
Yeah, that's coming up our next release. So we've integrated with NetHealth with Meet Expert, and Dr. Wahab's our first site for that. But that same technique is what we're using to interface with Epic and Cerner and so on.
Yeah. So they've interfaced with tissue analytics, and so then that can interface with so many of the other EMRs that are out there. So, yeah, so you can just see, we went, you guys did the demonstration when we were still talking. They're probably just, yeah, and those of you that want to, who have not utilized it.
So we were going to capture a picture because I didn't want his finger to fall off. We had the tourniquet on for quite some time. And I'm going to capture one more just to show you the hyperemic response, and you can compare the two. You can show them a visualization. I'll put the two side by side. Yeah, his finger was going to fall off if we didn't capture an image at some point.
So there you can, yeah, you can see, you want to,
What I'll do is some of
Yeah.
the side by side to show the trending.
right. So that, and this is the important thing I think that we do all the time, is that we're looking at the change over time, like we're talking about, and it is not linear. So we do need to understand, what's really happening. So with the tourniquet, you can see, with the tourniquet, you can kind of see that there's, a ischemic area there. And then without the tourniquet, how it's a hyperemic response there. So again, this is somewhat deceiving. You do have to have some clinical experience into understanding what do these colors really mean, and how does that look like over time. Any other questions? Yeah.
But it's very interesting. Sometimes I saw that the higher value means bad.
Yes.
Lower
Yes.
value is bad.
Yes.
That is, they can make it very hard. As I mentioned, it's really depend on kind of the application that we need to understand and digest these numbers.
Yeah, when we were first using it, that was one of our biggest issues. Everything looked like, just like even SPY, right? We were using it in the outpatient. There was a great fluorescence, and then you had to look at the the egress and the ingress and the this and the that. Well, now you do have to have that same technology that you have to learn how to read it, and so having a chronic inflammatory wound stuck in the chronic inflammatory state, a lot of times is going to give you a much greater response, a bright red response. And does that really mean it's healing? No, it does not. We need to go from that bright red response down to somewhat normal, have a little bit of a plateau, and then probably start to see that increase right up again, to really ensure that there is, again, as you're saying, it's not a linear response. So, yeah, we are absolutely seeing that.
Do you see this being used as a predictive occurrence and using it prior to this prevention?
Yeah, so some people are using it just to image the feet, the plantar surface of the feet prior to anything, as to see if there are areas that could be susceptible to a wound. And if that is one, to have earlier intervention, and or differing in shoe wear and things like that, could prevent that wound.
Do they allow you to, like, when you're coding your ability to use that support, does it get billed for preventative?
No, it does not get billed for preventative.
That's where they.
Yeah, it in some ways, but I was telling them that I really strongly feel that reimbursement on this is really not the key. It's really our predictive values and how we're going to be starting to utilize this in order to show closure, in order to, and right now it's great, and we're using it all in our research and our clinical studies, and it really it validates what we're trying to do. So I hate to belittle reimbursement, but I do think that it needs to be looked at a little bit differently, in the sense that as a clinician, I am now held accountable to heal this patient quickly. And when that patient says, well, I want to eventually say, well, when is this wound going to heal, Dr. Wahab? And I can say, oh, there's a predictive value that I could possibly tell them that this is when this wound is going to heal. That's what I would like to do. We're not there quite yet. We need much more data, but I think we're getting there. I think we're really getting there. So.
Yeah, actually, I have a suggestion. I don't know that whether it be here or not. That's even last year, CMS announced this value care reimbursement bonus. If you are showing to CMS that you can do outcome by using a technology, of course, you need to get the CMS and then showing some data, don't necessarily massive data. Then if somebody using and showing that the outcome, maybe can get 9% bonus on the revenue.
Yeah.
That might be some open to using this gadget, because we know that we can't manage what we can't measure. So having some measurement to guide us, it might be very helpful. Another application I thought that was very interesting, again, is part of the research that we have been using integral. So integral is 4,000%. We know that if patient doesn't have enough tissue oxygen saturation, if you're putting that integral on that point, it doesn't work.
Right.
You need to do one kind of rehabilitation to improve a little the amount of the oxygen saturation that this graph works. I was wondering that maybe that kind of application to explore.
Oh, I have, yes. So right now we have insurance contracts with private insurances, and they want to have a conversation with me every month. And so absolutely are we using this as a explanation for the progression of that patient. And also I'm going to flip this to say that I'm hopeful that CMS will give us bonuses for good outcomes. But I think what they're also going to use this for is that there's bundled payments. And those bundled payments are going to say you have this much amount of money in this much amount of time. And my concern is that we as clinicians have to get there in that timeline. And we all know that that's sometimes extremely difficult, especially with our patients and their non-compliance and their other comorbid conditions. And so that, to me, I want to get ahead of that curve. And I want us to know what that number is, both for healing, average healing times, and a really true monetary number that we can direct that with. So as clinicians. Thank you guys very much.